A very good morning to all of you. Welcome to the GMO Academica program. Today's topic is importance of maternal morbidity and mortality surveillance in preventing maternal deaths. So we have invited Dr. Harendra Dasanayaka, who is the consultant community physician, national program manager, maternal morbidity and mortality surveillance attached to Family Health Bureau. Dr. Dasanayaka obtained MBBS from Faculty of Medicine, Colombo in 2001, followed by MSc in Community Medicine in 2009, and MD in Community Medicine in 2017 from the PGIM Colombo. He completed overseas training at the Faculty of Medicine, University of Leeds, UK, and the Public Health England, UK in 2008. He is a board-certified consultant in community medicine since 2018. Dr. Dasanayaka has been attached to the International Health Unit, Ministry of Health, and the MRI Sri Lanka as a consultant community physician and currently serves as a member of the ethical and research committees of MRI. He also serves as a visiting lecturer for the PGIM and also for the Faculty of Medicine, Colombo, for postgraduate and undergraduate trainees. Dr. Dasanayaka is a master trainer in maternal and perinatal death surveillance for the WHO CRO region, and also he's a council member of the Perinatal Society of Sri Lanka and a life member of the College of Community Medicine Sri Lanka. So let me warmly welcome Dr. Harendra Dasanayaka for today's lecture. And if you all have any questions related to maternal morbidity and mortality, please send them over through the chat box. We'll attend to those questions at the end of the lecture. Over to you, Dr. Harendra.
Thank you, Dr. Charni. I welcome you all for the webinar. So our topic today is going to be, as Dr. Charni mentioned, role of maternal morbidity and mortality surveillance in reducing further maternal deaths in Sri Lanka. So I think you all are aware of the importance of maternal morbidity and mortality surveillance and the devastating effects of maternal death. So I consider this a timely discussion and a timely topic to discuss because we have been performing quite well in this area for the past so many years. And now it's time for us to further improve these achievements because now our maternal mortality ratios are low, and we need to work more on this subject if we are to reduce further. Because as known by everybody, this maternal mortality in a low mortality setting, further reduction is really difficult because we have already achieved so many targets, and further reduction needs more sensitive areas to be touched, and the quality part is very important. So having said that, we'll move to the presentation proper. So I think it's important for all doctors, for everybody to know the definition of a maternal death, because we work on this definition when we are categorizing maternal deaths and when we are trying to identify maternal deaths. So we to notify a maternal death, everybody should be aware of the proper definition of maternal deaths, and also in the Sri Lankan context, how a maternal death, at what what are the categories that you need to notify in the surveillance system. So I think you all are aware of this, but for the description, I will go through the maternal death the definition. A maternal death is a death of a woman while being pregnant or within 42 days of termination of pregnancy, irrespective of the Okay. Maternal death is a death of a woman while being pregnant or within 42 days of termination of pregnancy, irrespective of the duration, the site of the pregnancy from any cause related to or aggravated by the pregnancy or its management, but not from accidental and incidental causes. So, according to this definition, we don't consider the duration or the site. It could be a ectopic pregnancy, or it could be very early in pregnancy, and we go on till 42 days of termination of pregnancy. So this is very important because especially the early pregnancy and the postpartum period, sometimes when mothers get admitted to hospitals for reasons other than medical the obstetric problems or gynecological problems, if they get admitted to a surgical ward or a medical ward, it's very important that you identify this mother as a maternal in the maternal category. So that is why this definition we mention all the time, because we are expecting 100% notification of maternity. So we have achieved almost 99, not I think it's almost 100%, because we do active surveillance for maternal mortality. So and we have the system is such that the field and the hospital sector, that is the institutional level and the field level, both notify maternal deaths, and the criteria is to notify within 24 hours of occurrence. So when we go into further categorization, we come across direct obstetric deaths, indirect obstetric deaths, then coincidental maternal deaths, and late maternal deaths. Now, the importance of these categories is that when we are calculating the maternal mortality ratio for a country, this is the global accepted phenomenon. When we are calculating the maternal mortality ratio, though we notify all the maternal death, now in Sri Lanka, the requirement is all death of a mother within this particular period, that is from conception up to 42 days postpartum, and further up to 1 year postpartum, we request the maternal deaths to be notified. That is because we need 100% notification. Then after notifying only, we do the separation from the other categories, because we only use the deaths up to 42 days postpartum for the calculation of maternal mortality ratio. But the notification go up to 1 year postpartum, because then we are sure that we get 100% notification. So with that, we look at the direct obstetric and indirect obstetric deaths. These two categories are the ones we use for the calculation of the maternal mortality ratio. So direct obstetric deaths are the deaths that those results in complications of pregnancy status, that is pregnancy, labor, and the puerperium, from interventions, omissions, or incorrect treatment. So any intervention done due to the pregnancy, and omissions, if you stop something, and then incorrect treatment, or form a chain of events resulting from any of the above. So that is now you can understand why we call this direct. This is directly related to the pregnancy or its management. Then we go to the indirect obstetric deaths. Those are resulting from previously existing diseases or diseases that developed during pregnancy, and which was not due to direct obstetric causes. So it's not directly pregnancy or its management related, but diseases that have been there. Say, for example, a mother with heart condition, pre-existing heart condition, and with the physiological changes of pregnancy, if this mother develops any further changes, or say she develops pulmonary edema and other complications, which is like a development from the previously existing disease, then we categorize them as indirect maternal deaths. So these two categories we take for calculation of the maternal mortality ratio. That is the global accepted norm. And the coincidental maternal deaths are deaths that are unrelated causes, which happens to occur in pregnancy or puerperium. So if you consider a mother who's traveling in a vehicle and meet with a road traffic accident, and when she dies, if she dies, it will be a coincidental cause. So coincidental causes we don't consider in calculating the maternal mortality ratio, but the notification is a must for even these deaths. The coincidental deaths also need to be notified. Then we come to the late maternal death category, the death of a woman from direct or indirect obstetric causes more than 42 days but less than 1 year after termination of pregnancy. So those are the late maternal deaths. Now, when we notify all the deaths up to 1 year, we go through the documents, we do the proper analysis and see whether this is a late maternal death. And then we take them off the calculation. But all these maternal deaths will be properly investigated, and the institutional and the field level investigation process will be conducted for all these maternal deaths, and then we decide which ones will be taken to the calculation of maternal mortality ratio. So then this is a bit of a complex diagram. This is just for your understanding. This is how the data flow and the process of maternal death surveillance happens in Sri Lanka. So the Family Health Bureau, the Maternal Morbidity and Mortality Surveillance Unit is the central point where we do the analysis for the Ministry of Health. And all these documents and the notification, all those are sent to the Family Health Bureau. And we collect all the information once the death is notified, and then we go on the procedure. And I have mentioned several new things, which I will explain in the coming slides. So what is important in maternal mortality surveillance? This is very important as doctors working in different levels, maybe in the peripheral level or in the hospitals, the general hospitals, or in this tertiary care. So whatever the place, and also the private sector only working doctors, all should know these categories. This is the identification of a maternal death. So we go by the given definition, and any doctor, any healthcare worker should be able to identify a maternal death. So if you properly identify according to the criteria, then the next step will be the notification of a maternal death. So if you come across a maternal death, and if it's at the hospital level or even in the field level as a MOH or a hospital doctor, or even as a medical officer working in the private sector, it's very important that you identify this and then do a proper notification. Now, if you are a doctor who's working in the private sector only, you can always inform the MOH of the area regarding these maternal deaths. But fortunately, most of the maternal deaths occur, the majority of the maternal deaths occur in the hospital sector. So hospital notification is a must. So whatever the ward the mother is admitted to, if the criteria is met, everybody should make a note that this has to be notified. So notification requirement is from occurrence within 24 hours, the maternal death has to be notified. So the hospital notification should reach the institutional head. Then the regional and provincial directors should be made aware, and the director MCH, that is the director of the Family Health Bureau. Or you can directly notify to my unit, and you can use any method and there's a format which is used for notification, which is available in the Family Health Bureau website. Or else you can even send it as a, so you can send a fax, you can send a letter, you can send a WhatsApp message, whatever possible way. We need to get the notification in within 24 hours. And the field notification, again, that is also within 24 hours. The medical officer of health, that is the MOH, is responsible for doing the notification, the field notification. So it is also to the Family Health Bureau and the regional director and the medical officer, maternal and child health should be made aware so that the procedures can be started. So when the notification is done, we will, from our unit, that is the Family Health Bureau, we will be sending request for certain documents. The BHT, in the hospital, the institutional level, the BHT should be taken over by that is, should be kept with the hospital, the institutional head, and a certified copy should be sent to the Family Health Bureau, and all other relevant documents, maybe investigations, maybe other records, whatever the records available should be sent as a it should be properly numbered. The BHT should be properly numbered, and then a copy, certified copy, certified by the institutional head, should be sent to the Family Health Bureau. And from the field, we require all the field documents, even the eligible family registers and the family planning records and the mother's card. The PHM has a B portion. The A portion is usually coming from the hospital because when she gets admitted, it will be available at the hospital. So even the A portion and the B portion all should be sent to the Family Health Bureau for the documentation and then processing of this review process. So then the institutional and field level investigation. This has to be completed within 2 weeks. So we have made some changes. The field investigation definitely should happen within even more than before 2 weeks. It should happen, and the medical officer of health along with the medical officer of maternal and child health from that region should visit the household and get the information and fill up the H677A format, which is the field investigation report. So that has to be filled and it has to be sent as early as possible to the Family Health Bureau. And then the institutional investigation, it is also should be held within 2 weeks. Sometimes there is a small lapse, but we try to get the information, the institutional review also done within 2 weeks. And now, after the institutional review, the H677 format should be filled and sent. Now, this institutional review, we have made some changes in the near future. So near past, so we have strengthened the institutional maternal death review because we expect to make recommendations related to the occurrence of the maternal death as early as possible. Now the new system is the institutional maternal death review will be represented by the Family Health Bureau, and the College of Obstetricians will be participating as experts to review the case at the institutional level, and the recommendations will be identified, and then the recommendations will be forwarded for implementation as early as possible. And following this, after collecting all the information, a desk review will be conducted at the central level with the participation of multidisciplinary team. Now here we collect all the information and we invite a team of experts. Depending on the case, we invite now say, for example, if the medical related maternal death, we invite the medical specialties. Then say it's like postpartum hemorrhage. So we need the support of the anesthetist, then the transfusion specialist, the pathologist. So all these categories, including the forensic pathologist and always the SLCOG membership will be participating as experts, and there we will decide whether this maternal death, the cause of death which was given, whether it's acceptable and whether it's it explains the occurrence of the issues, and then the preventability. And we go by the 3 delay model, where the delay 1 is the patient or the mother deciding to go reach medical help, and then delay 2 is reaching, that is first one is seeking, second one is reaching, and third one is receiving. So at the household level, they have to decide, we have to seek medical advice, and then they have to find a way to get to the hospital. And the third one is receiving. Once you get to the hospital, receiving medical care. So these will be decided on these basis. The maternal death will be analyzed, and then the recommendations will be made according to what we identify as issues. Now, one thing we have to always remember is this is not a fault-finding exercise. This is always a fact-finding exercise where we try to identify the issues related to the system issues related to a maternal death. And we synthesize evidence so that the evidence-based practices can be implemented. So this is our main target, and it's not trying to identify fault with people and trying to punish them. But we have to always make a point that we always consider the accountability. Have I done what I am supposed to do? So that need to be considered, because we are expected to deliver a certain level of services. So whether we have abide by our responsibilities. So that is something we consider, but it's not a fault finding thing, and it's we always try to keep it as no name and no blame. So with this, we generate recommendations, and then we use that information to assess the progress of our interventions, also to see whether we can improve and how we can improve the system issues to prevent further maternal deaths. Now, this is where our the team, the medical teams, the doctors, nurses, and everybody need to get updated on these interventions and the recommendations, because these are the issues that we have identified, and these are the things that we recommend, not we in the sense the expert panels recommend to further prevent maternal deaths. So it is very important that we share this information with the relevant stakeholders. So after the final desk reviews, the report we generate is disseminated to the entire country. And after the institutional reviews, the recommendations that come, that is then and there, the recommendations we make available to the relevant hospitals and the regional teams, so that they can work on the regional level implementation of recommendations. So now another thing I want to mention is conducting postmortems. Now, for a maternal death, it's mandatory to have a postmortem done. So it is by circular, it is mandatory to do a postmortem. Now, this is important in now, as I said, because when you if you falsely categorize a death as a non-maternal death, it is a proper maternal death, you won't you may not require a request for a postmortem. But it is very important to identify the proper maternal deaths and then categorize it and then request for a postmortem. And the requirement is the postmortem should be done by a consultant JMO. For all maternal deaths, the postmortem should be done by a consultant JMO. So this is by circular, it's a requirement. So that is very important, because when we are coming to decisions regarding the cause of death and the way it has occurred and the gaps, identifying the gaps, it's very important to have a proper postmortem. Even in during the COVID time, a full postmortem was done for all maternal deaths, where where it was performed under the cautious conditions. So this is how, these are some pictures of how the review process goes. These are the institutional reviews and the desk reviews, which happens in the field level, the institutional level, and the central level. So then we have now introduced, as a pilot project, we have introduced a confidential inquiry into maternity. This is inquiry. This is not inquiry. So you should be always think about this E rather than I, because this is also not a fault finding thing. We do this, we have introduced this to Western and Southern provinces in 2022. And the difference here is we have a set of formats which will be used by the caregivers, the main team who got involved in the management of the patient. These formats will be anonymized. You all are filling this format. It should not contain your name. And there are the formats are for different categories. For the consultants, for the ward doctors, then the nurses, and all the relevant parties will fill this format separately, individually. And you are not supposed to discuss and write. The idea is to get the information and the inputs of individuals regarding managing the particular patient. So they may have different ideas, but these ideas will not be seen by the others. So what the requirement is, you fill this format by yourself and put it in a sealed envelope and seal it and then hand over. So nobody will keep copies, nobody will keep any documentation on this. Only the review panel will go through this, and your names or anything is not available in this formats. So what we need is proper information so that we can continue the process, and we have nominated experts from all professional colleges who will go through these documents. And the documents, even the BHT, will be anonymized, so the reviewers will not know from where this maternal death came and where this information came. So this is a process which is currently being used in developed countries. So this is a further improvement in the maternal mortality surveillance system. So we need to go to this level if we are to come down in the maternal mortality ratio. And in the next slides, I will show you how it has gone down, and what are the things that we need to consider, because our rates, the reduction rates are very low now. So now looking at the data, now in this process, this is the data that the latest data that is available. So these data, these numbers and the ratios are calculated through this maternal mortality surveillance system, which is not an easy task. And all of the contributors, that is from the institutional level, field level, and the central level, they all contribute to this process. So as you can see, in 2020, up to 2020, there was a reduction in maternal mortality ratio, and this is the number I'm talking about. The number, as you can see, in 2020 was 89. So we were looking at two-figure maternal mortality numbers, which was 89. And as you can see, in 2021, there was a very high rise up to 134. So we all know why that happened. That is because the COVID outbreak, we had 60 maternal deaths due to COVID. So COVID was considered as a indirect cause. Because it's an indirect cause, COVID contributed to this high rise of maternal death. So we had reported 134 direct and indirect maternal deaths, out of which 60, that is a majority as a single cause, was due to COVID. So with COVID, our maternal mortality ratio went up, and also this is a global phenomenon where in many of the countries, most of the countries, almost all countries, the maternal mortality ratio went up due to COVID. So now when we look at the 2022 data, we can see that it has come down, but not to the expected number. So that data is still being processed. And this is the ratio. Now, there's something that you have to consider now. Looking at the numbers, 2019 it was 93, and 2020 it was 89. And looking at the ratios, you can see that 2019 it was 29.2, but with a reduction of 2 maternal deaths, the ratio has gone up 0.3. Now, the reason for this is the denominator. The maternal mortality ratio is calculated by dividing the number of maternal deaths, direct and indirect, divided by the total live births, and it's given as per 100,000 figure. So now when the denominator goes down, that is the live births go down, we don't get the expected maternal mortality ratio due to the reduction of the number. So though the number has gone down, we can see the ratio has gone up. So this is another challenge we are having, because since 2018 up to now, the maternal mortality ratio has gone, the maternal the live births, number of live births has gone down dramatically, because in 2018 it was something around 360,000, whereas by 2022 it has come down to 275,000. So we are looking at we are trying to reduce maternal mortality ratio with the reducing denominator, reducing number of live births. So I'm talking about this because this is why we need to work harder, because the numbers go down very slowly. The numbers go down in small numbers, but the denominator is going down in thousands. So then our target is difficult to achieve. If we continue with the present conditions, we need to further improve. And then looking at the district-wise data, you can see there's a vast variation where at least around half of the districts have the maternal mortality ratio higher than the national average, which is 47.04. So districts like Galle, Kandy, Badulla, Trincomalee, Batticaloa, Kurunegala, those are the ones which have less than the national figure. All the others are higher. Now, in districts where the live births are less, even a single maternal death can give a very big number. But this is, now when you look at the, I have not included here, but when you look at the numbers and the ratios, when we remove the COVID, the maternal mortality, the national maternal mortality ratio becomes 25. So 26. So 47 becomes 26 when the COVID is removed. So you can see the effect of COVID on maternal death by looking at these figures. So still, it's a problem. So and looking at the causes, now this is another important area where you can see the cause-specific maternal mortality is going to be very high for COVID. And when we remove COVID, then we see the other things like heart disease coming as the second commonest cause, and obstetric embolism, then obstetric hemorrhage, and abortion and ruptured ectopic, so on and so forth. We see all these issues. Now, one may ask why, because previous years it was respiratory diseases was very high, And one may ask why respiratory diseases are not that high here. That is because the COVID, there was a superimposing of COVID with the respiratory problem. So it is hidden with the COVID-19 deaths. So the other causes, as you can see now, heart disease, if you consider heart disease, the heart disease, this is not the traditional, once you know, the congenital heart diseases, the valvular defects, those things were the common things earlier. But now it has changed. It's things like cardiomyopathies and then myocardial infarctions. Those are the things that affect mothers as heart diseases now. And then obstetric hemorrhage. When you look at obstetric hemorrhage, you can see that there are 8 cases, and obstetric hemorrhage is always considered as a preventable cause, and then we can't prevent all maternal deaths. There are non-preventable maternal deaths as well, but the preventable portion should be considered in great detail, because it's a tragedy when a preventable a mother dies from a preventable cause. As you can see, the causes, then when we go to the delays. Now here you can see in the upper 2 lines, the delay number of mothers who were affected by the delay was identified. Now you can see delay is present on 109 maternal deaths, that is 81%, and no delay was seen in 18.7. Now then these no delay ones most of the time goes to the non-preventable portion, but delay was present in 81.3%. And when we consider the different delays, delay 1 was seen in 105 maternal deaths. So delay 1 is seeking. So we have a big responsibility in making awareness among the mothers regarding the danger signs. I will come to that, regarding the danger signs, and enable them to decide that we need to seek medical advice now. So that is very important, because without that, they will not come to the hospital, they will not reach. So fortunately, delay 3 was seen in only 13 cases, and delay 2 is usually very less, but as you can see, that also have contributed to maternal deaths in 8 cases. And then the preventability. As you can see now, when you compare 2021 and 2022, the preventable portion of 2021 was much lesser, much higher than the 2020 figure, because the COVID maternal deaths almost all were considered as preventable. So that is why this has gone up. That is why I have mentioned now 2 previous years also. As you can see, in 2020 it was 47%, while it has been coming down now. 2018 it was 40. This is the 2018 one is wrong. It was 58 as I can remember, but 2019 it was 57. So it was coming down. Then 2021 2020 it was 47. So it was coming down gradually, but with COVID we had a big problem in the preventability. So and then we have now discussed several new interventions, establishment of these MPDSR committees at institutional levels, where maternal death surveillance will be now. When we consider all these facts, we have understood that we need to have a more focused system within the institution to do the reviews and to analyze these maternal deaths and perinatal deaths at the institutional level. So we have included several new interventions in this process, one of which is the Maternal and Perinatal Death Surveillance and Response Committee establishment at the institutional level. So that is another topic I just want to mention. In your hospitals, in all hospitals, down to the base hospital A level, we have requested with the DG's circular, we have requested for these committees to be established island-wide. So this has to be followed up at your institutions, whether this is happening and how often it is happening. So I will talk about in another, maybe in another session, but just to mention that there is something like that also. Then the confidential inquiry, as I said, a new methodology currently being used in UK and other developed countries, and the collection of individual anonymized formats is the here we ensure that strict maintenance of confidentiality. Now, the most important part, which is the notable issues in maternal mortality surveillance, what we have identified. Now, first and foremost is complex social scenario. Now, you have to understand the poverty and sexuality issues, and then the social issues have come to the forefront in patient care these days. And the women in danger should be identified and properly managed. So because with the poor social conditions, they tend to avoid things like seeking medical care for smaller illnesses, but the nature and the complexity of the illness they are having is disregarded when the social issues and the financial issues come up. So these things have to be considered when you all are working. And now, say for example, if a public health doctor or a public health team member identifies a mother who's in danger of dying due to his or her illness, her illness, this red book has to be initiated. So it's a document available in the MOH office where a mother, if she is in risk of dying, should be entered in this book, and these mothers should have a plan of management, not the regular marking red on the antenatal card, but when they are entered in the red book, they should have a separate management plan. Just entering in the red book is not enough. You have to have a separate plan. You have to discuss with the team, with the PHM of that area and the relevant teams, and plan of management should be given by the institutional head, mainly the medical officer of health. Then issues in family planning, then documentation and data quality. Now, family planning issues are very much seen because so many issues. Sometimes the cultural barriers, sometimes the poor understanding of the mothers and the family regarding family planning, then the stigma, all these things are there. The commodities are available, but introducing them at proper times is very important. And then proper follow-up is the most important. Then suboptimal field and hospital care. So we talk about the quality hospital care and the field care, but there are gaps, there are problems that we see in the hospital level and field level. So these has to be, that is as healthcare providers, it's our responsibility to maintain a quality care at field level and hospital level both. Then seeking care, when you talk about delay one, the mother should be empowered to identify risk factors and danger signs by themselves, and the care providers, and also the family members, the patient and the care providers both should be able to identify. So they should be updating their knowledge, the care providers, and then the patient should be, the mother should be given proper directives. If you have this problem, you should do this, and it has to be strict advice. Otherwise, they will take it lightly. And now, if you find a mother with high blood pressure when they come for an antenatal clinic, you should make sure that they go to the hospital, and you should follow them up. And even in the private sector, if you see a mother with high blood pressure, you should make sure that is your responsibility. You work as a family doctor, so it's your responsibility to make sure that they reach the proper health care. And then unavailability of prioritized care for pregnant and postpartum mothers at first contact. Now, when a mother comes to say a postpartum mother, when she's having a baby, she's very reluctant to come to the hospital setting because you have to stay in line, and go by the OPD lines and get the treatment. So we should have a proper way of identifying these mothers and having a sort of a triage system so that they can be cared and sent home, because of this the problems they face at the OPD level, they tend to go to a private sector doctor and they don't want to come to the hospital. And even when they are referred by the private sector doctors, the general practitioners, they don't want to go there. They try to avoid that general practitioner and go to another one just to avoid getting admitted or coming to the hospital. So this is a very big problem when we need to work on it to have a prioritization system to prioritize these pregnant and postpartum mothers. Then the lapse in initial assessment of and management planning at the first contact. Now, when a patient mother comes to a OPD setting, we need to properly examine them, and now when they come for confinement, if they come to the hospital, we need to properly identify. These are the things that I understand by going through the documentation. These are not done, and that has caused problems. So you need to properly examine at your level and not wait for the ward people to come and see, but at the OPD level also, you should do your assessment, and you should have a plan of management, which may include calling the SHO from the ward or the registrar or whatever. So then the lost focus on maternal patients. So that is when they get admitted to medical wards and surgical wards for other problems. Especially these early pregnancy mothers and postpartum period mothers, the pregnancy and the maternal part is forgotten. And even when if they die also, they don't call for a postmortem because that pregnancy part was not considered. So that has to be considered at all levels, at all units. When they are admitted for something, you should make sure to get in the history whether they had a recent pregnancy or even a miscarriage. They are considered maternal patients because even a miscarriage, they had a viable pregnancy and then they miscarried. So they are considered maternal. So from the post miscarriage date up to 42 days, they are considered maternal cases. Then the documentation. I'm sorry to say that the documentation, the maintenance of BHT and field records has so many errors, and these are in one way for the management of patients. It's a big problem, and the BHT, as everybody knows, it's a legal document. So maintenance of a proper document is mandatory to get the proper outcome. And when in the review process also, the documents will speak for you. And when the expert panel go through the documents, they find out so many issues and they consider them as issues. But sometimes you have done everything, but it's not properly mentioned. And the time, mentioning the time and mentioning the person who has attended, all these things are having problems. So these we need to improve the system. Then guidelines not followed up. So we have guidelines for many of the obstetric management. So these guidelines should be properly understood and properly used. So guidelines can be in the cupboard, or you can have it in your, you can use it day to day. So that is very important to go by the guidelines and make every effort to go by the guidelines and make sure that all the provisions are available to manage the patient according to the guidelines. Then late interventions. Now timely interventions, getting the patients ready for surgery, and then getting them ready for, now looking at the patient's report. Even one example is, if the mother's HP is low, you don't wait for the protocol amount of blood loss to consider it as a massive hemorrhage, because the patient is starting with a low volume, so low HB, and the minimum loss will cause problems. And also the BMI, body mass index. If a low body mass index mother is there, the volume of blood is low. So then the loss less than 1000 ml will cause problems. So all this has to be properly seen and then understood, and the management should be planned accordingly. And then the multidisciplinary care should be initiated early. As a medical officer in an OPD setting, you should call for all the specialties to manage. If you are a medical officer in the OPD level, even that level, you should, and the emergency care, you should always call upon all the multidisciplinary team members, that is all the specialties, if necessary, to come and see the patient and give a multidisciplinary decision making on the management of the patient. And ward setting, it's a must that the multidisciplinary teams should get together at the patient's bedside to make decisions. Not a multidisciplinary team does not mean that you can give opinions over the phone, but you have to come and see the patient, and at the bedside you have to decide all together, so they can discuss and come to the final management plan. This is something we have identified in many maternal deaths, the need for a multidisciplinary on bedside multidisciplinary team decision making. And then things like pneumonias prevention. Now we have circulars for admission of mothers with 1-day fever. So these circulars should be used, and also when they come, you should be able to identify them in the private sector also. When they come, if the pulse rate is high, if the respiratory rate is high, then you have to consider all these new problems that are coming up, and then consider timely admission. Otherwise, you will miss the opportunity to early interventions. And these golden hours, as we talk about in medical management, the golden hours will be lost, and then the patient, by the time they reach the hospital, they will be in a very bad condition. Then postpartum monitoring. Now we use partograms, and Mears charts are there. So now considering the Mears chart, modified early warning signs chart, which is to be used after the delivery for a mother. Now it is color coded. Now it's very easy when if you mark it properly. The color code will tell you if the danger signs are there. It will be red, and you should act upon. Now this is very important that you do the proper monitoring and maintain the partogram and Mears chart, so that you are alert and you know when to take action. So these you have to have it, you have to maintain it, and you have to properly interpret it. We have seen in some instances very nicely maintained, but the interpretation was not done, and we have problems. So these you have to look into. Then administrative failures, as you know, there are issues with the manpower, and all these things has to be attended by the administrative level. And this is something I want to stress: poor communication between the GP system and the and other private health institution system with the public health and the government institutional system, because we all manage a patient, and we need to have a coordinated care. Otherwise, the patient will be moving from this to that, but the care, the management plan will not be communicated, and then we will have problems. So even in the GPs, we have a big problem in like capturing the GPs, because our GP system is not that like established, but the GPs, they provide a big care, they do a big role in providing care. So this link should be made somehow, so that the communication regarding the patient should be properly done to the relevant points. And then Another issue which is coming up is the inability to identify postpartum psychological issues. And you may have heard there have been many postpartum depression and postpartum blues mothers who had committed suicide. So this is also something you have to, even if the patient is in the hospital or maybe due to the child's issues, if they are in hospital, you need to keep an eye on the psychological status. And then another problem among us the medical professionals, is lapse in knowledge updating and refresher training due to poor participation. We conduct trainings, we conduct awareness programs and knowledge updating programs, but the poor participation is something that we have to consider, because we need to update our knowledge. New things are coming with these the evidence-based practices are coming, and you need to update your knowledge. So with that, we need to have the administrative support, ensuring of smooth functioning of the institutions, then availability of proper guidelines and protocols. It should be made available the wards and the doctors and the nurses and everybody to see. And then the regular monitoring should be done, whether these are happening properly. The supervisions must be done. And then the self-assessment, you need to, as institutional administrators, you need to work on your you should be looking at your data and then analyzing and trying to identify the problems that each individual is having specifically, and it should be attended, so that the recommendations and the recommendation implementation can be followed up. So with that, I just like to mention that when guiding principles of planning response, you have to always start with available factors identified during the review process, then use evidence-based approach to implement. Then you should be able to prioritize based on prevalence, feasibility, cost, then resources available and resources you need to find, and the health system readiness. Then establish a timeline. You should always have a timeline, so that you can, this is not only for maternal death recommendation implementation, but in every aspect, when you are planning a response, these should be considered, and a monitoring should be, system should always be there, even at individual institutions level and even at your individual ward level, because then you know what are the factors you are facing, what are the trends that you are having, and what you need to work on. And then again, when a response plan is developed, you need to prioritize, then proper recommendations to address the three delays, then identify deadlines and personal responsibilities, then develop mechanisms for implementation, identify additional resources you need. You may have resources, you need to find out what are the resources need more for implementation, and then you should plan for implementation. So when you do that, for you to do this, you need to do a proper surveillance, not only the national level surveillance, but at your own institutional levels, you need to do a proper surveillance, so that you have proper data and you can look at your trends and you can act. So actually, then we have a system for maternal severe morbidity surveillance as well, which requires the identification and notification of severe morbidities. This has been there for quite some time, but the influx of information is very less, and we need to work on this. But the reporting system is available, and on the Family Health website, it's mentioned. So these are the things that I needed to talk to you about regarding maternal mortality surveillance, how important it is to reduce further maternal deaths. So the support from your end, the medical, the healthcare team, as doctors and any other category, your help is always needed to carry out this process and to improve the system. So we are looking at as a millennium the sustainable development goal, we are looking at reducing maternal mortality ratio to at least 16 per 100,000 live births by 2030, which is a big task, but we can achieve if we work together. So thank you all for listening. Have a good day.
Thank you very much, Dr. Harendra, for that very interesting lecture and for sharing your insights on maternal mortality and morbidity surveillance in Sri Lanka. And we have one question from our participant. Some patients are completely followed up at private sector, and some patients are in estates. Some patients who are in estate areas, especially in Badulla and upcountry areas, they never come to a hospital, even for a delivery. So, according to your experience, what are your opinions on this?
So actually, yes, this is a problem that we have seen now. Some patients, even in the more urban areas, who are seeking medical care, the follow-up care from the private sector, they don't get registered and they don't come to the government sector. But it's very important, and we are working with the College of Obstetricians and Gynecologists also on this to make awareness among the consultants to make it mandatory for them to sort of request the patients to go to the private sector, get registered, and get the proper care from them while getting the shared care from the institutions and the hospital, the private sector consultants if they want. So that is why we need shared care, and we have made several attempts, and we are in the process of introducing that. And regarding the estate sector, I think it's the responsibility of the now estate. Previously, the estate health sector was provided. The healthcare was provided by the estate medical teams, but now we have taken it over by the government system. So the MOH system is the key provider of maternal care for the estate sector as well. So if you see any issues like patients not coming to the hospital settings and home deliveries happening, so then we need to act upon some. We need to discuss with the estate level and make provisions for them to reach the hospital. Now, these are the problems. They don't have enough leave, and they don't have proper facilities. And these estates, even the 1990 ambulances can't reach them. So that we need to discuss and get the facilities available for them. The public health teams should work on it with the regional administrators, and then multi-sectoral coordination is needed, because we can't do now. We can go and build roads, the health sector, but we have to have the coordination. We have to communicate to the proper authorities regarding the problem that we are seeing, and then we can as a temporary measure, you can always do satellite clinics and visit the. Now, when I was an intern, we used to do that. So those are the things. Those are not the permanent solutions, but the awareness regarding the importance of this shared care and the hospital admission, hospital deliveries, all these things has to be communicated to the that level, and in the process you can use the health promotion methodologies, and also use the community leaders and the estate administration to get help. So that is one thing we are very concerned, and I think it's important that we work on it.
Thank you very much, Dr. Harendra, for that elaborated lecture. And let me thank all the viewers for joining us today. and see you in 2 weeks' time.